Good evening. I, Dr. Prakashveer Arya, welcome you all in this super specialty webinar on adolescent gastroenterology. I welcome our guests from CIAP, OB and EB from CAHA, faculties, resp- members, our youth participants in this webinar along with the extreme participants attending this webinar. Now I invite Dr. Sushma Desai ji, Chairperson, Acting Chairperson, Center AHA, for her opening remark and few words over the webinar and welcome speech. Dr. Sushma ji, please.
Very good evening to all of you. It's been the 10th of the series of super specialty webinar under the President Action Plan of Dr. Hima Bindu Singh. And all the webinars were extremely successful and very, informative. Today also we have esteemed speakers from all over the country and they all are expert in the field. And icing on the cake is Dr. Neelam Mohan Madam, the guest of honor with us. And she is the expert in this field who doesn't know that. And because she is in hurry, probably I would invite, before I welcome, I think Dr. Khalatkar has come. Sir, welcome Dr. Khalatkar, sir, the chief guest of today's webinar. So, ma'am, should I call first Dr. Khalatkar sir's comments? Yeah, sure. Thank you, ma'am. So, I invite...
Neelam, you can. I will.
नहीं sir, वो sir आप.
No issue, yaar.
Sir, so...
Abhi just from Bangalore.
Yeah, our chief guest, Dr. I welcome. It's a warm welcome extended to our oil-selling IAP President, Dr. Khalatkar sir, to give blessed occasion and give the expert comments on this webinar. Please.
Yeah. Good evening, all. Respected Dr. Neelam Mohan, our incoming president, our Dr. Yogesh Parekh, Secretary General, Indian Academy of Pediatrics, Sushma, it's one of the loving personality in adolescence. Is always smiling, and I know next year will be some superb year will be there in adolescence.
Thank you, sir. Thank you so much.
Yeah, so Dr. Prakashveer Arya is very active and leading a good role of secretary. Sharma sir, Agra to jana hi padta hai. That is very important. And all the adolescents member, my dear friend, all that. See, adolescents, there is no senior junior. They all dear friend, including Bansal sir, is the past recent leading the adolescent chapter. I bring greetings from Indian Academy of Pediatrics and wish you a very happy and prosperous Diwali, not for the member but all the adolescents who are our future and for whom you are fighting like anything. That's why IAP is again celebrating International Adolescence Week. And I think later has been our Dr. Yogesh Parekh has been sent a letter to you people to how to celebrate, and if you please work on it and we will do the best of the best for that week also. So actually today's topic is the actual topic of Dr. Neelam. So I will not talk much about this. So once again, I wish you all the best for this work and academic content. Thank you.
Thank you, sir, for joining and sparing your valuable time. Ma'am, our guest of honor, beloved Dr. Neelam Mohan Madam, the charming lady, amidst us, and the expert of the experts. So, ma'am, I welcome you and I request you to give your blessings as well as your expert comments. Ma'am, please.
Thank you, Sushma. Respected Vasanji, Yogesh ji, who despite being so busy still makes it a point to be available, which is truly applaudable. And when it comes to adolescent, the biggest chapter, not only in terms of the numbers, but in terms of a variety of people who are so senior and so Pleasant, Dr. Sushma, Dr. Geeta, and Dr. Arya and Dr. Shamek, who have been really doing a wonderful job for the last year. We have today amongst us seniors like Ajit and who make it a point to attend the adolescent thing. And I'm quite impressed to see Praveenji also participating in the meeting besides Dr. Sharma. And wow, what a panel! You know, I'm so proud of this panel. I mean, my whether it is the moderator Naginder and whether it is the panelists, right, starting from Rim James, Ashe, and oh yes, the lady who seems to be a gastroenterologist, but now has is doing phenomenal work, Rachna, in WHO job. Wish you nice to see you. It's so lovely to have you over. And then the Pai as well as who's there. I am missing. There is a youth here, if I'm not mistaken. Is it Kalyani, her name?
Yes.
Kalyani Pariyar.
Yes, ma'am.
That's
Good evening, ma'am.
good evening. You look the most beautiful, so I guess you must be the most youthful. So it's indeed a pleasure to talk about. When we talk about this, just a little glimpse. There are two ways. When we talk about adolescent, we talk about physical and mental health. Even with mental health, liver, GI is the first organ to be affected because all psychosomatic, so we have GI issues. And then when we talk about adolescent health issues, obesity, again, um, the truth is it's not the diabetes, it's not the insulin resistant, all is secondary to the effect of the cells being affected by the fat and in the liver. So the biggest culprit before the other organs get affected. This is the new theory which we've been talking about last half a decade and decades. So a lot of people on that. Without taking much time, I would congratulate the stupendous amount of efforts the adolescent chapter is doing to empower the more than 20 million people who are adolescents. And of course, we need to understand that adolescent is a part of pediatrics. So just like the other specialties, so adolescent is a big chunk, like we talk neonatology, but you have to be under the umbrella because it is the IAP, which is the big umbrella because all see adolescents. And my message to adolescent chapter is to walk shoulder to shoulder and not with a head up saying that we are the ones who are adolescent and see pretty because they would be incomplete without the multidisciplinary team. And with those few words, I wish you best of luck and a very amazing Diwali and a 2026 under the leadership of Sushma. With
Ma'am.
thank you
Thank
so
you
much.
so much, ma'am. Thank you so much for being with us today and
And,
sharing your extremely
happy Karwa
valuable
Chauth
time.
to all the ladies for tomorrow. Those who have not gone in for your mehndi can go after the meeting.
Oh, thank you, ma'am. Thank you for being with
Okay.
us. So,
Sharmik, your
and
smile is.
happy anniversary, ma'am, once
You
again
have to
from all
snatch
of
your
us.
smile.
Thank you, ma'am.
Okay.
Okay.
Thank you.
Now
And
I
I'm
invite our
also
respected HSG, Dr. Yogesh Parekh, sir, to bless the webinar and say a few
again my
words,
best
sir.
wishes to you. Do a great job.
Yeah, thank you. Thank you, ma'am. Thank you so much.
He's a special guy to me.
Yeah,
Thank you.
thank you, ma'am. Thank you.
Thank you, Sushma madam, for and Geeta Patil madam for inviting for this wonderful workshop. This our today's program on the adolescent gastrology. I think the adolescent chapter under the leadership of Dr. Sushma madam, Dr. Geeta Patil madam, and Dr. Prakash Virarya ji, Dr. Shamik Ghosh, Dr. Aryan Sharma sir, Rajit Chawla sir, and many adolescents experts are working on it, and they are best chapter at the our Dr. Neelam Mohan madam mentioned. So I think you people are working hard to make this organization, not only the AHA, but the IAP, on the credible and the charity work. So this is the, I think something uh, to give to the society. Sorry for because my throat is not proper since last many days. Continuous walking, working, and talking on the phone. So I
Too much
welcome our
busy.
President, Dr. Vasant Kalatkarji, and Dr. Neelam Mohan Madam. And I think Dr. Nagendra here, the expert of the not only the adolescent gastrology, but the whole gastrology chapter, and my dear friend. So he will deliver best on the management of the fatty liver in the adolescents. We know so many causes for the fatty liver, and he will enlighten on this all cause. Dr. Shamik, I know him, he's a good friend, and he will moderate on this wonderful youth voice with this our topic on the IBS and the related disorders in adolescents. And along with the youth voice, Dr. Kalyani Pariyar. So, as Madam mentioned, she the beautiful young adolescent here, and she will be the uh, really youth voice for this today's program. So
Thank you,
panelists,
sir. Thank you for the opportunity.
panelists, Dr. Rachna, Dr. Anu, Dr. Ashay, Dr. Ramya, and Rimjim. I know Rimjim is with some personality is very close to all this activity. She is sending so many messages every day. And Rachna madam, we met with this on the WHO working group. So you people are excellently delivering this all. And thank you very much. Best wishes, Sushma Madam, for next year program along with your team
Thank you.
and the guiding force
Thank
like
you.
the P. Bansal sir, Tuteja Saab, and many adolescent experts. So thank you and happy Diwali, happy festival season to all of you. Thank you.
Thank you, sir. Thank you for your generous words and comments, sir. I now invite our past president, past chairperson, Dr. Geeta Patil, madam, to say a few words.
Thank
Ma'am.
you, Sushma ji, for giving me opportunity. As you mentioned that this is a 10th segment of the super specialty chapter, and so far all previous ones were very well attended and appreciated. And gastroenterology is not commonly discussed in the adolescent age group. Always we stop at gastroesophageal reflux, and beyond that many things we don't discuss. But now time has come. Obesity has increased, fatty liver should be there. Functional problems, mental health problem, emotional health problem, irritable bowel syndrome is there. So many functional diseases we have to treat. So it is a very appropriate topic chosen, which is required for us to know everything which we don't discuss commonly. Recurrent abdominal pain, that is the commonest thing we get it, and we don't know many times the reasons. So thank you very much and wish you all the best. And I know Nagendra sir very well, Rimjim, I have seen her sharing many important things, and all other youngsters. So we will listen to them, and this will definitely will benefit us when we are managing the adolescent patients. Thank you very much.
Thank you, Geeta ji. Thank
We
you for being
started
with
with
us
the
today.
blessing of our Vasant Kalatkar sir, Neelam Mohan madam, Yogesh Parikh sir. Thank you very much. All of them, Kalatkar sir has just came back from Bangalore because I talked to him at 5:30, 6 o'clock. And then Yogesh Parikh sir, I requested him, he was telling he has to go somewhere. Neelam Mohan madam, I think she told this is a Karwa Chauth day. So she be particular. So we have to remember she could spare time. Thank you very much. When there is IAP, blessing is there with AHA. AHA will go forward. And AHA all is full of passionate, sincere, community work oriented AHNs are there. And all the pediatricians are adolescent ambassadors. So it will definitely will help if IAP, AHA work in the collaboration, and we expect a lot when Dr. Sushma madam is going to be there next year. Thank you very much.
Thank you.
Thank you, Geeta ji, being with us today and bless the webinar. Without, I think, taking much time, I heartily welcome all the dignitaries from IAP and AHA. I may not be take everybody's name, but I'm really happy to see the speakers today, right from Dr. Nagendra, who is well known, Amizas, and Dr. Shamik, always a very enthusiastic, knowledgeable, and with a very, very, I would say high level language essence and other stuff. I'm so very happy to have him with us. There are stalwarts of the field. As a panelist today, we are so very blessed to have them all with us. Right from Dr. Rachana Katuria, Dr. Anu Vasu, Dr. Ashay, Dr. Ramya, and Dr. Rimjim. They all are excellent. And of course, Dr. Kalyani Parihar as a youth voice. So I welcome you all. And now I request Dr. Prakash Virarya to introduce the first speaker and begin the webinar.
Okay, thank you, madam. Thank you. Before inviting Dr. Nagen Kumar ji, I acknowledge Dr. Sudhir Mishra sir dedication for coordinating these super specialty webinars. Her work is and dedication is remarkable. Dr. Sudhir Mishra sir, आपने साल भर बहुत काम किया सुपर स्पेशलिटी वेबिनार में
Thank you
कोऑर्डिनेट
so much, sir. Thank you.
Thank you, sir. Thank you, sir.
Sir,
Now
Sudhir
I
Mishra sir,
invite
please do a few words from you, sir.
sir.
Sudhir Mishra ji, sir.
Thank you, ma'am. Thank you,
Sir,
ma'am.
sir, few words, sir. आप बोलें, sir.
Sir,
Nay,
please.
see, I continue to do the scientific committee work,
Thank you,
whatever
sir.
is
Thank
required.
you, sir. Thank you,
And
sir.
that, if you appreciate that, that's my reward. So just go and listen to the experts rather than wasting time on this. Thank you
Thank
so
you,
much.
Thank you, sir.
Thank you,
Thank
sir.
you once again. Thank you.
Now I invite today's guest speaker, Dr. Nagen Kumar ji, VR, PD, CCDM, pediatric gastroenterologist from SGPGI. He is a leading consultant department of pediatric gastroenterology and hepatology and liver transplant unit, Rainbow Children Hospital. He is honorable consultant of Indira Gandhi Institute of Child Health. His achievements and awards are many more. Multiple award-winning presentation in national and international conferences, national IAP consensus for probiotic use in children, Young Investigator Award for oral paper presentation on prospective evaluation of sclerosing cholangitis in autoimmune liver disease in 51st ESPGHNA annual meet held in Geneva. Many publication in national and international journal involved in teaching module. Sir, I invite you for your guest lecture, sir. Dr. Nagen Kumar.
Yeah, thank you very much, sir. It was a very good introduction. Again, I would thank AHA and IAP for giving me this opportunity. I thank Dr. Prakash, Dr. Sushma, Dr. Shamik, and Dr. Geeta. Yogesh sir is here. So, I mean, without wasting much time, I'll get into topic. But this is my first interaction with AHA as a group. I'm extremely thankful and extremely happy to be part of you. In fact, before joining gastroenterology, when I was doing my MD pediatrics in Surat, I was interested in adolescent medicine, but later on, later on somehow I got into gastroenterology. So
I know
I'm
that.
again,
Yeah.
so I'm very happy to be part of you and the scientific program. So without wasting much time, I'll get into the topic. Can I share the screen?
Yes,
Please.
please. Yes, please.
Yes. Can you see my screen?
Yeah,
Yes.
please make it full
Yes.
screen. Yeah,
Yeah.
excellent.
Yeah. Thank you very much. So basically, so today we are going to talk about management of fatty liver disease in adolescents. So far, we have heard about gut-brain axis and so many things. I think there is something called as liver-brain axis, especially when it comes to adolescents. This term is not yet coined, but I feel that majority of the times fatty liver is due to the brain, basically, especially in adolescents. And I'll come into the various details how the fatty liver happens and how to manage them, especially in adolescents. And why the fatty liver disease is so important. Geeta ma'am was telling that now there is a time we should think about irritable bowel syndrome, we should think about fatty liver disease, because there is a phenomenal increase in the prevalence of obesity. And I was a author of one of the paper I did in school children in Surat, where I found that at least 25 to 30% of children were overweight or obese. So that is the level of prevalence of the overweight and obesity. And definitely fatty liver is going to increase with the time, and especially in adolescence, and you would be seeing more and more. And it is very important to identify early and manage accordingly. So what is the problem with the fatty liver? So fatty liver or cirrhosis due to fatty liver is one of the commonest indications of liver transplantation or even death or cirrhosis in adults after alcoholic liver disease. And now we are more and more able to capture hepatitis B and C. So now the next in line is fatty liver disease. So pediatric NAFLD has serious long-term implications, especially for the public health, and we need urgent and appropriate intervention. So why every one of us should know? It's not about we managing the patients. I think uh, even I realized that it's for every one of us. Even we are not giving that much importance in our busy clinics and hospital visits. Either we are unable to give time to the patients or ourselves. I've seen that our lifestyle is very bad sometimes, and we do also get fatty liver. And I have had a colleagues and senior colleagues also, even from pediatric fraternity, who had a liver transplantation secondary to fatty liver disease, cirrhosis due to fatty liver disease, and his son is also having fatty liver and is also having steatohepatitis. So it's not only for the patient management, it's also for our own management. We should be aware of the serious implications of fatty liver disease. So we should be very authentic ourselves before counseling the patients. So previously it was said like non-alcoholic fatty liver disease, but now the terminology is very confusing, and it is very, I mean, it's not a very good terminology to say non-alcoholic. When you are not alcoholic, something like non-alcoholic, you are just focusing on one of the etiology. But pediatric NFLD is defined as chronic steatosis in children less than 18 years. But remember, especially in children, all fat in pediatric liver is not NAFLD. Yogesh Parikh sir said it's not about only about NAFLD is just a steatosis. It's a complex of many disorders, especially when it comes to pediatric fatty liver disease. Why it is so? You can see the various causes of fatty liver, but this is a very comprehensive list, but there is lot of etiologies which I didn't include. But you should remember, mostly we see it with inborn error of metabolism or metabolic disorders like glycogen storage disease, tyrosinemia, fatty acid oxidation defects, mitochondrial disorders, hereditary fructose intolerance, and so on. And there are some medications like glucocorticoids or ART, which can cause fatty liver, and rapid weight loss or protein energy malnutrition can cause fatty liver. And then infections like hepatitis C, and there is extensive small bowel resection or pancreaticobiliary diversion can also cause fatty liver in children. So we should be considering all these disorders before saying this is pure fatty liver disease or non-alcoholic fatty liver disease. So why I'm saying so? So in King's College, there were biopsies done in 441 children with hepatic steatosis. You can see at least one third were actually inborn errors of metabolic disorders, and and small percent, like around 10%, didn't had any reason why they developed steatosis, and remaining 50% were basically due to fatty liver disease. Now, when you see a fatty liver disease in children, it can be any of these three. So when you see any child with fatty liver disease, these are the ways you need to approach. Now the problem with there was no proper terminology. So for last decade or two, we were saying NFLD or pediatric NFLD, pediatric fatty liver disease, or metabolic dysfunction associated fatty liver disease. So there were so many terminologies that went among circles and discussed. Finally, right now, we are saying it as metabolic dysfunction associated fatty liver disease, not a non-alcoholic fatty liver disease. From now on, mostly I'll be describing NFLD in terms of metabolic dysfunction associated liver disease, and I'll be focusing more on metabolic associated dysfunction, associated fatty liver disease than other causes. So whenever a child you have suspected steatotic liver disease, you need to check, does this patient have cardiometabolic criteria? What is cardiometabolic criteria? If there is a BMI more than 85th or 95th centile, fasting blood glucose are high, more than 100 milligram per deciliter, or HbA1c is pre-diabetic levels 5.7 or 5.8% or above, or diabetic levels, of course, and then postprandial glucose levels of more than 140 milligram. Third is blood pressures, higher blood pressures or on antihypertensive medications. Fourth is plasma triglycerides are quite high, and low HDL cholesterol. So there are five things. One is BMI, second is glucose levels, third is blood pressure, fourth is triglycerides, and fifth is HDL cholesterol levels. So if these criteria are met, so then you think that this is probably metabolic dysfunction. So if there is no other causes of steatosis based on the clinical or biochemical parameters, you didn't find any other reason, then it is just MFLD. But if there is some other cause, apart from this, there is already cardiometabolic criteria. And on the top of this, if there is a overlap of other conditions like Wilson disease, like other metabolic liver disease or drug induced, so then you can say MSLD overlap. And if there is no other causes of steatosis and there is no, the cardiometabolic criteria is not fit into, then we can say it cryptogenic. And if there is, the criteria is not fitting but there is a fatty liver, then you should think about other causes like drug induced and inborn errors of metabolism. With this small idea, like cardiometabolic criteria is there or not, and is there any other cause or not, based on this you can arrive at the various different causes that is causing fatty liver disease. So what is a problem statement? How much it is there? I mean, we all know in our practice that it is increasing day by day, but how much? You can see this data from China, and it is multicentric data. Over 27 years, the incidence increased from 19 million to 30 million. Okay, and it's not only it's increased from almost around 80 to 90% times, 90%, and annual increase is of 1.3% every year on year. And you can see it's not only about higher socioeconomic status or high middle socioeconomic status. You can see even in low socioeconomic status and low middle, so across all the socio developmental indices, you can see that the prevalence is increasing even in young adults also, more than 20 years. So definitely we are going to see more and more number of children with the as time advances. So you can see that the prevalence varies from place to place, around 5 to 10%, and in some countries it is as low as 2 to 3%. But in India, we have a significant amount of fatty liver disease. And you know, BMI for us is lesser than the other Western countries, 2 points lesser than other countries, because we are genetically much more prone to develop overweight, obesity, and type 2 diabetes mellitus, and even for that matter, fatty liver. So you can see almost 60% of overweight and obese had fatty liver disease in Mumbai, and around 20% had fatty liver disease with normal weight also, and around 40 to 50% in obese, and similar trend you can see in multiple studies. So basically, with normal weight in children in India, the fatty liver was between 3 to 22%. When I'm talking about fatty liver, I'm just talking about MFLD, not about the other etiologies. And in obese children, around 30 to 60%, which is on par with global data, or maybe India is slightly on the higher side of fatty liver disease. So what are the reasons why it is increased nowadays in adolescents? And not only in adolescents, young adults, old adults, everyone, it is increasing. That is because of our diet. 80% of our diet is composed of simple carbohydrates. Even if most of us can introspect our own diet, I can tell you for sure that 70 to 80% of our diets are made up of sugars or carbohydrates, and in which predominantly it is simple carbohydrates than complex. And we have our diets are significantly less in proteins and healthy fats. And second is lifestyle. Of course, increased screen time, addictions, reels, and all these things, sedentary lifestyles, increased screen time, increased stress, and all this together contributing to lack of sleep. Sleep is, I think, very, very important. I mean, lack of sleep is it increases the belly fat and increases the overall obesity and also fatty liver. So all these reasons why I think we are seeing more and more fatty liver disease. This is a study from US and multi continental study, where you can see the pediatric obesity has significantly increased over a time, more than maybe 3 or 4 times. And you can also see that high fructose corn syrup consumption and increase in obesity rates. So simple sugars are killing. Simple sugars are causing obesity, overweight, and fatty liver. So what happens exactly in fatty liver? So there is a normal liver, there is a genetic predisposition, and there are some genes which predispose to develop fatty liver disease. And then the added to that, if you have a poor diet, sedentary behaviors, lack of sleep, lack of physical activity, it causes increased accumulation of fat in the liver, and that fat again sits in the liver and starts causing oxidative stress, inflammatory injury, and then fibrogenesis. All these things put together causes cytokine cascade, inflammation, and that's how we develop steatohepatitis. So there is no ongoing damage when there is a fatty liver. This is just fat is sitting idle. But when it comes to steatohepatitis, there is hepatocytes are getting damaged because of oxidative stress, and which is replaced by the fibrosis. That begins the process of cirrhosis, and then further leading to hepatocellular carcinomas, or cirrhosis, decompensation, leading to death, or leading to liver transplantation. So that we generally don't see in children, but we see it in fourth decade, fifth decade, sixth decade in adults. So metabolic dysfunction associated fatty liver disease can be stable, I mean even lifelong also, but in small proportion where they are genetically predisposed, especially they can develop steatohepatitis, which leads to cirrhosis, hepatocellular carcinoma, or liver transplant, or even death. And not only that, not only about the diet and physical activity, there are a lot of food additives, preservatives, chemicals, which can cause problems. And again, I'll tell you, obesity is not only about genetics and diet and activity, it's also hormonal. So you all agree that the hyperinsulinemia and insulin resistance is one of the very important cause which causes the fatty liver. And these are all the various chemicals which can disrupt the endocrine homeostasis, and can cause obesity or overweight. So now we all know that what is the reason for MFLD, and why it is on rise and what magnitude it is increasing. Now, how will you approach a child uh, where when you suspect MFLD? First, you need to identify target population. So you need to see in whom I should think about fatty liver disease, and then look out for red flags. What red flags I should see, so that I just think there is no other etiologies, or should I work up for the other causes of fatty liver disease? Look for cardiometabolic criteria, which I have discussed, and then investigate accordingly or properly. No need to investigate too much. It's not diagnosis of exclusion, it is a diagnosis of inclusion. So often it is asymptomatic, making it very difficult to identify sometimes. But if there is obesity or overweight, definitely you should see. If waist circumference is more than 70th percentile, or if there is a hypertension, diabetes, or dyslipidemias, definitely you should look for fatty liver disease. And if there is a acanthosis nigricans, menstrual irregularity, again you should think about fatty liver disease, especially in the setting of overweight or obesity. Lack of concentration, daytime sleepiness, that is because of lack of sleep, obstructive sleep apnea, and they may present with mild abdominal discomfort, fatigue, weakness. Generally they are asymptomatic, but fatty livers children, I mean, I think these symptoms are not per se because of the liver dysfunction. I think this is overall about the metabolic risk, metabolic problems that this any person or child is having. And family clustering. Just now, half an hour back, I saw a child with fatty liver, obesity, gallstones, and father is also obese. And fortunately, is in army, so he is able to maintain his diet and activity. And mother is obese, and even she has fatty liver. So definitely, family clustering. It's not only about genetics; it's also about the common pot, what they're eating, and family dynamics. Last week I saw one child, adolescent boy, very depressed. Again, he had a acanthosis and pre-diabetic HbA1c. But there is lot of family issues. Mother and father, I mean, they have a argument every day. This boy is getting depressed and he's channelizing all his depression into eating, and he's overeating, and he doesn't like to go out and play. So this family clustering. So if you see one person, so in that family, I think there will be a lot of them will have fatty liver, and they may end up coming to you rarely with the symptoms of liver disease, especially if they have advanced fibrosis or portal hypertension or splenomegaly or jaundice. But that we generally don't see in children. Generally, we see it in adults. I have not seen child at age of 12 or 13 coming with cirrhosis secondary to metabolic associated fatty liver disease. So what are the red flags? So if you see very young child with fatty liver, like 6 years, 5 years, less than 8 years, you should always think about metabolic liver disease or other causes. If you see, previously we used to call it as lean NASH. If someone is not overweight or obesity, that should trigger your, that should ring the bell. So you should look for other causes. Growth failure with fatty liver. Generally, these children who are obese and overweight are exogenous obesity, so they will be tall, or at least their growth won't be affected much. So, but if there is a growth failure, developmental delay, syndromic features, presence of splenomegaly, and if there is a liver dysfunction already happened, like hepatic dysfunction is there, especially synthetic liver parameters, we should consider for other causes, and family history of liver disease, or if there is a multisystemic diseases. These are the conditions where you should think beyond metabolic dysfunction associated fatty liver disease. So what you should do once, okay, you have identified, yes, this person has a probably fatty liver disease, how will you screen? Will you do CT? If you do MRI, you do what? So basically in our practice and in Indian settings or any settings for that matter, simple ALT or SGPT along with ultrasound abdomen. Okay, so these are the two tests which is sufficient to identify steatosis. Ultrasound basically shows that there is a fat in the liver. ALT generally says that is there any inflammation which is going on in the liver or not. Basically, MASH is there or not. So these are the recommendations. Most of the recommendations are from Indian Society of Pediatric Gastroenterology, which was held in last year. So they have given an excellent review on management of fatty liver disease in children. I think whoever is interested, all of you should go and read. It's published in Indian Pediatrics. So what is increased SGPT? Is it 30 is more considered as more, 40, 50, 60? We don't have a Indian data, but safety study which has showed 26 IU per liter for males and 22 for females between the age group of 12 to 18 is the optimal cutoff value. So when should you worry? North American Society of Pediatric Gastroenterology has suggested twice the upper limit of normal, like 52. If it is more than 52 in boys and 44 in girls, it should be considered as a significant elevation of SGOT and SGPT. Sorry, significant elevation of SGPT. Now, some child walk-ins and you got a LFT because he's overweight, ultrasound showed fatty liver. But one value of 60, suppose a boy had a SGPT of 60, that doesn't mean that he has a steatohepatitis. There are so many causes, and even simple viral fever, some medications, some food additives. So all these things can cause transient elevation of SGOT and SGPT, transaminases basically. So you need to repeat it after some time. At the same time, you can start treating like a fatty liver disease, but no pharmacotherapy. But you should follow up and see. There may be other causes of liver disease like autoimmune liver disease or some other metabolic liver disease, or it can be just because of the fever, recent medications, it can increase. So don't jump immediately and think about metabolic dysfunction associated fatty liver disease. So apart from ultrasound is a very good modality. Both have a sensitivity of more than 80 to 90%, both ALT and ultrasound, but they are very low on specificity. And ultrasound per se can just tell, it has a good sensitivity only when there is a severe steatosis, more than 80% or 90% is a sensitivity. When it is a mild steatosis, then the sensitivity drops to 30%. So there is still a lot of research, a lot of papers are there which are looking at a lot of biomedical parameters, and then radiological techniques, non-invasive methods which can detect the fibrosis and quantify the steatohepatitis. So one of them is fibroscan or transient elastography. Nowadays, it is easily available, and with some contacts, I'm able to get it for free of cost also. So it was expensive previously. Now the device is available. So now, if you have a child with elevated, there is a fatty liver and there is elevated transaminases, but you want to know that is there any fibrosis set in already. So liver biopsy is one of the technique to see the liver fibrosis, but it is invasive and expensive also, especially if you are in metropolitan cities, and if you are in corporate hospitals, sometimes it becomes very difficult. So you can easily get something like transient elastography, which will detect how much fibrosis it is. Still, we need lot of data and validation in children, but adult data is there, and fibroscan value was more than 7 or 8 is significant. So that is very easy tool, and child any age we can do it, and there is no need for invasive thing, and the child is not cooperative and all. Then CT and MR, CT again carries the risk of radiation. MR elastography is quite good, but it's quite cumbersome and expensive. and then even 2D shear wave elastography on ultrasound, which can be done, or acoustic radiation force impulse on ultrasound is again a very important technique. You need a separate software, otherwise the probe and everything with the ultrasound machine is will be same. So these are all the ways you can identify fibrosis. What is gold standard to see fatty liver or inflammation and fibrosis? It is liver biopsy. So should we do in all children who has elevated SG transaminases and fatty liver? The answer is no. So you should do, especially when you think that there is some atypical or red flags. If child is less than 80 years, high index of suspicion of advanced liver disease, you don't know the etiology, but there is already advanced liver disease, you want to see that is it because of the fat or something else. When you consider alternate diagnosis and as a part of research, again, I don't know how they'll get a ethical clearance, but as a part of research, they can do the liver biopsy. And those are the recommendations by ISPEGAN, but there are some recommendations for American Association of Study of Liver Disease in adults and North American Society. Essentially, all of them are similar. Basically, before starting pharmacotherapy, if you are looking, if you are thinking that there is an advanced liver disease already, if you are thinking other causes, younger age, so these are the conditions when you should actually think about liver biopsy. There are lot of advances in screening, but as of now, ALT and ultrasound is what recommended across the societies. So now you know that how to pick up which case, how to evaluate initially. Now, how will you treat or even prevent in overweight and obese children? So there are some modified risk factors. Obesity is definitely modifiable. Waist circumference more than 95th centile, sedentary lifestyles, diet, improper sleep, breastfeeding, all these are modified risk factors. While some Hispanic origin, genetic polymorphism, low birth weight, or parental obesity, family history of NAFLD or diabetes mellitus or a metabolic syndrome. So all these factors are there, especially if someone is having these risk factors, you should start treating them or counseling them even before they develop cirrhosis or steatohepatitis. What is the basic principles? It's weight loss and modifying the diet and modifying the activity, pharmacotherapy, and rarely bariatric surgeries and endoscopic treatments. So what is about diet? I mean, I think all of you know this. There is nothing new in this. Hypocaloric diet, low carbohydrate, low fat, low sugar, which focus on weight loss may be considered. And then it's not about only low. I think you should have a good amount of protein and complex carbohydrates and healthy fat. See, most of us don't have adequate protein, so we lose muscle, so we lose basal metabolism. And what happens, all the food go and sits in the liver, and which gets converted to fat, and which starts depositing and leading to second hit or leading to oxidative stress. So food should contain higher polyunsaturated and monounsaturated fatty acids, and packaged, processed, frozen, and high sugar containing foods and beverages should be avoided. So this is a traffic light concept. I think most of you know this, and I'm not going to expand on this. And so the most important step is weight loss. So without weight loss, you can't manage fatty liver disease, regardless of what diet child is having, what activity child is doing. So the ultimate outcome we want is weight loss. And there is some data on Mediterranean diet in low in saturated fatty acids and high in plant-based proteins, antioxidants, fibers, but still the evidence is not much. We can't blanketly give a recommendations, but definitely you can suggest. And ketogenic diet, again, there is no data in children. What about exercise? So moderate to high intensity exercise is definitely helps in weight loss, and it is again effective measure. So now, what is the problem in adolescents? For that matter, for us also, you can see there is two odd owls among the group. So they are adolescents. Okay, so they are completely different. Their mentality is completely different. I think Sushma madam and Dr. Prakash, all they can add in the end. So I think they are totally different, and even doctors who are treating them should have different mentality and approach. So the problem is sustainability. So that is not only with adolescents, even with us also. So they are often very careless. They are very emotional, not listening. And I see so many times mother and especially girl child and mother quarreling right in front of me when we are having a consultation. So most of the times I have to intervene, because the moment mother says complaints, she want to vent out her frustration and the child starts arguing. So that is a problem. So what is the problem of adolescents? Adolescent stands for A, problems of A's. The to extent all of us definitely, they are very adamant. So they are like, okay, if parents start telling something, oh, always you come and lecture me because I know everything. So this is a age when they want lot of freedom, but still they don't have a experience of handling the things. Affordability, now things are very much affordable. So previously one dairy milk affording one chocolate was so difficult. Nowadays it is easily affordable. Parents are becoming rich. Lot of people are coming above the poverty line. Availability, because of the supermarkets and also it is easily seen, and lot of people just afford to go there and pick it up. And nowadays I mean, even my daughter says put it into I mean, like home delivery apps, Zomato, Swiggy and all these things. Nowadays things have become very easy and it is very much available. Previously it is not. Addictions, of course, because of more availability and affordability, they are getting into addictions. It can be glucose addiction, sugar addiction, food addictions, craving, and lack of physical activity. And then advertisements, the huge advertisements and YouTube reels and all these things are putting more exposure to the kids. Academics, so definitely academics, they have a lot of complicated subjects, peer pressure, stress. I see nowadays the adolescents waking up till 3 o'clock, 4 o'clock for the studies. They have online courses, offline courses. Amenities are lacking, especially city like Bangalore and metropolitan cities. If someone wants to have a some physical activity, exercise or sports, it is not very easy and affordable. And then associates or friends and family, it again depends on friends and the family, what are their dietary habits. And ancestral, so at least they will definitely inherit the genes, and they also have a similar environment. So like the family I told I saw half an hour back, similarly I mean, there is a clustering of this overweight, obesity and fatty liver. So I can say that adolescents with the problem of all these A's are overweight, obese and having fatty liver. So this is also objectively shown in the study. In this study, basically there were two groups. Both were advised to do a regular diet and exercise. All were almost 79 were obese children, and so everyone's target was to decrease the weight and improve the laboratory results and hepatic triglycerides content. So at 16 weeks, everyone showed good response, both in group 1 and group 2. But when you look at the 68 weeks, there was no sustained response in group 2. And even in group 1, there were some weight gain, but group 2 is like completely, because group 1 had some more counseling sessions, motivational interviews, behavioral modifications. Despite that, there was still some in group 1 regained some weight. So consistency, discipline, this becomes very, very difficult. It is easily said than done. So that is a problem with the fatty liver. Once someone gets into fatty liver, it becomes very difficult to maintain them out of the fatty liver, overweight, and obesity. This is a serious issue. So there are multiple suggestions. This is again from Indian Society. So what needs to be done? This is very busy slide. I'm not going line by line, but this is there. As adolescent practitioners, I think you all should see this, how, what remedial measures and what you can help. I think fatty liver disease, it's not about pediatrician or hepatologist or gastroenterologist. It's also about the counseling and psychologist, and I think the psychiatrist and psychologist will become a will have a pivotal role in the management of fatty liver disease in children. So there are some other pharmacotherapy. I told you pharmacotherapy only if there is a significant steatosis causing inflammation, then only you should try. And still we don't have very effective drugs when it comes to pharmacotherapy. Still the main treatment is weight loss, and second main treatment is weight loss, and third is again weight loss. So there is definitely, people have shown that firmicutes are very high in obese compared to, sorry, coliforms are very high when it compares to firmicutes in gut microbiome. But again, we don't have any definite probiotic role in terms of preventing or decreasing or treating fatty liver disease. Metformin, again, it is used to treat insulin resistance, but not recommended across the board. It is associated with hepatotoxicity. So only if there is a insulin resistance which is documented, you can try. Otherwise, it should not be used, and you should not never use in advanced liver disease. By far, among pharmacotherapy, the highest evidence, it's a landmark study, is high dose vitamin E in children. It's a tonic trial. So basically, NASH resolution in children at the end of 1 year, you can see it from 58 to 28%. Again, it's not only about the drug, it was weight loss, diet, and vitamin E, and without vitamin E. So that was a RCT which was done. So you need to use high dose, almost 400 IU/BD, for as long as 1 to 2 years. But again, it's only if there is a NASH you should consider, but not in children who just have a fatty liver. If there is no inflammatory activity, don't use it, because we don't know how long to use. So mostly we need to use 1 to 2 years. And ASLD guidelines also suggest vitamin E may be used to treat children with biopsy proven NASH, not like just a fatty liver disease. Just a fatty liver disease is no problem. There is no liver injury is happening. Only thing is you need to reduce the fat from the liver. So there are various drugs, GLP agonists, liraglutide, semaglutide, which you can use more than 12 years of age, and Orlistat in adults, metformin, vitamin E. So again, this is all should be used if there is associated type 2 diabetes mellitus or insulin resistance. So otherwise, simple fatty liver disease or NASH, there are no role of other pharmacotherapeutic agents. So I'm not discussing about bariatric surgeries and all those things. Uh, I know a lot of people get bariatric surgeries. Even a lot of politicians had bariatric surgeries who are obese, overweight, and having NASH. And there are a lot of endoscopic therapies where we place a big balloon in the tummy, in the stomach, so that they're always feeling full, they don't eat. Or we have a sheath like thing which coats over the intestine, which prevents the absorption of nutrients. And we can staple the stomach in the through the endoscope only. But again, there is not much data in children about the safety and long term effects. So I think for us, a treatment is very simple but yet very complicated, because it's all about personality or lifestyle change that we need to make. It's not very easy just with the one OPD visit. I think we need a help from psychologist who can discuss with them. That's why in the beginning of the session I told it's not about liver, it's about the liver-brain axis. Okay, so that is very important here. So to conclude, pediatric metabolic dysfunction associated fatty liver disease is on rise and parallel with obesity and globalization, and typically diagnosed between 10 to 13 years or 10 to 18 years. And you need to carefully diagnose because there are other causes of fatty liver disease in children, especially metabolic liver disorders. And lifestyle intervention and weight loss are the first line target or first line treatment. And it's not about just counseling and sending them back. We should have some mechanism, and I think adolescent society should take it up to have some sort of teaching or some app based or some feedback based, something we can do as a community. And vitamin E can be tried, especially if there is a biopsy confirmed steatohepatitis. And other anti-obesity medications may help, but we need to be extremely cautious and monitor them for side effects. Again, we don't know how long we need to use. That is also a problem. And at the end of the day, the basic foundation for the treatment is weight loss. With these words, I would like to thank you all for your patient listening. I hope the session was interesting and I didn't bore you all. Thank you very much.
Thank
Yeah,
you,
yeah.
sir.
Thank you, Dr. Nagendra ji. It was very much in-depth description of fatty liver disease, which enlightened the funda and weight loss, and weight loss. We have got an idea about it. Another thing is multidisciplinary, management for the fatty liver disease. Thank you so much for an elaborate deliberation. And I would request you please to go through. There are 2 questions for you in the chat box. And can you please type the answers because we are running short of time. So we would like to start another session. Thank you
I'm
once
sorry, I
again.
didn't had an idea how much time I should take. So thanks
So
for
anyway,
giving me
it was,
elaborate time. You didn't mention the time, so I took all the freedom to
No, it was
give
a
all the
nice session.
तो
information.
बहुत
And
इंटरेस्टिंग
we are
टॉपिक था,
thankful to you.
इंटरेस्टिंग आपका
Right.
प्रेजेंटेशन था सर.
Yeah. So
Thank you.
now we invite Dr. Shamik Ghosh,
Shamik Ghosh.
our own, to start the moderating the session. Dr. Shamik Ghosh is a highly talented, a true scientific mind, the sweetness overloaded, and the Joint Secretary of Central AHA. I invite him to start the session. Thank you, Dr. Shamik, for pitching in as a moderator. And I would like to, I request you to introduce your panelists. Thank you all the panelists for being with us. And we look forward to having a great session ahead. Thank you.
डॉक्टर शामिक के लिए थोड़ा सा 2 शब्द और बोलना चाहूंगा. ही इज ए चार्मिंग, हार्ड वर्किंग, गुड ओरेटर एंड हैविंग एक्सीलेंट कमांड ओवर द टॉपिक. He is the Shashi Tharoor of the AHA.
Great.
Thank you. Sir.
Thank you, Dr. Sushma Desai, and thank you, Dr. Prakash Arya, for those very kind words. What I can promise is that we won't be speaking anything that people will not understand. All right? Okay. So I'll straight away go to the panel discussion. But before that, I do have a duty to be introducing my panelists. So we have Dr. Rachna Kathuria, and I'll be extremely brief because we are a little short of time. So Dr. Rachna is a very, very well-known person, not only nationally, but she has had her contributions to public health on the WHO platform. She is here today strictly in her expertise of pediatric gastroenterology, which she received as a training. Her medical graduate training was from KGMC, King George's Medical College. And then she had her super specialty training at SGPGI. I'm not going into the details, but she has a special interest in pediatric gastroenterology, has had a number of publications, and is with us here today to contribute to an interesting discussion. We also have with us Dr. Anu Vasu. Dr. Anu Vasu is a consultant pediatric liver transplant physician, a hepatologist and gastroenterologist at the KIMS Health in Thiruvananthapuram. Her areas of interest include liver transplantation, immunology, and pediatric metabolic disease. We have Dr. Rimjim Srivastav, a very well-known figure. She is a consultant pediatric gastroenterologist, hepatologist, and interventional endoscopist, primarily at the Ekta Institute of Child Health and the Swapnil Nursing Home in Chhattisgarh. She has huge, experience, has authored chapters, and has also multiple publications. We also have with us Dr. Remia R. Pai. She is a consultant pediatric gastroenterologist from the Lisi Institute of Gastroenterology from Kochi, and her special interests are pediatric, irritable, inflammatory bowel diseases, motility disorders, liver transplant, and bowel USG. Dr. Ashish Shaha was also due to join us, but he's had a family tragedy. So some of his questions will be shared by the other panelists. And I will straight away move on to my presentation. And the first panelist whom I would want to introduce today's topic of the IBS is Dr. Rachna Kathuria. So if you can just throw some light and introduce the topic to us. Dr. Rachna.
Thank you, Dr. Shamik, and thank you to IAP for bringing me to this platform, and thank you to my sincere regards to Dr. Neelam, Dr. Geeta, Dr. Sushma, Dr. Prakash Virarya. And especially, it's great to have a session after one of your junior colleagues has performed so well and he has given a wonderful presentation. Nagendra, we are so proud of you. And just to add on to that slide of adolescents, that the adolescents are the odd owls. So I would rather add that they are, rather than being odd, they are the unique ones. So with their own peculiar needs, and so let's, I suppose that they should not be called odd but unique. So coming on to this session's topic panel, functional GI disorders, this is a broad term. So it actually has various entities included in it, which includes functional dyspepsia, it includes irritable bowel syndrome, it includes abdominal migraine, and those pains which are not classified in the above three categories, they are included as functional abdominal pain, not specified category. So this is a broader term, functional GI disorders, and irritable bowel syndrome is the most common of them. So if we say the prevalence, the worldwide prevalence of pooled data of irritable bowel syndrome is around 8.8%, and in India we can say even 10 to 15% cases have been found to have irritable bowel syndrome. Now to classify this functional GI disorders, there is a standard criteria which was made by a non-profit organization called the Rome Foundation in 1987, and they created a Rome 1 criteria, which was later, it went to 2, 3, and 4, and now we have the Rome 4 criteria, which was compiled in 2016. And it's basically a symptom-based diagnostic criteria for functional GI disorders, and it does not support many investigations to diagnose this entity. It is a standardized diagnostic framework for diagnosing irritable bowel syndrome as well as other functional GI disorders in all age groups. So the characteristic of this Rome 4 criteria as compared to Rome 3 is that pain has been considered as a diagnostic criteria rather than discomfort, which was a very vague entity, and it is more specific and more like it rules out the organic etiologies better than the earlier criterias. So the frequency, if there is a recurrent abdominal pain, that is the pain is occurring multiple times, but at least 1 day per week for 3 months, then we say that this is falling into the irritable bowel syndrome category, and it has to be associated with any two of the below factors. First is that pain is usually related to defecation. So it is either there's discomfort or pain after the bowel movement. Also, the frequency of stool has changed. Now we need to keep in mind that this frequency is not a set frequency. It is the frequency from the baseline. Whatever frequency that particular adolescent has a baseline, that has changed. Suppose an adolescent goes twice a day for his bowel movements. If it has become 3 or 4 times, then we say that this is a change in frequency. This might be more for another child who goes once per day, but for one who is going twice a day, going 3 or 4 times is the change in frequency. So it's different, change from the baseline frequency. Then there's also change in the form or consistency of the stool. So there is a Bristol stool chart. If anybody of you wants to refer to that chart, it is a stool chart based upon the consistency and the shape of the stool. There are 7 categories and they classify the stools as hard, loose, or normal. So there's if any 3 of these criteria are fulfilled, any 2 out of these 3, then this falls into the IBS. Next slide, please. Now, what is the specificity, why this Rome 4 criteria has come up? So I told you that this is like pain has been considered as one of the key features rather than discomfort, which was more vague. So there were a lot of non-specific irritable bowel syndrome coming up initially. Now this has narrowed down. And the symptoms have to be chronic in onset. That is, the duration has to be long. For functional GI disorder, this varies from 2 to 6 months. So like it can be 6 months for abdominal migraine. For IBS, it's 2 months. And also it has to have an impact on the daily activities of the adolescent. It has to impact the quality of life. It has to interfere with his or her daily activities. And the other conditions, the other organic conditions need to be ruled out only when there are alarm symptoms or red flags. Otherwise, this is basically a standard clinical-based diagnostic criteria, not requiring any extensive investigations unless and until there are red flags.
Thank you so much, Dr. Rachna, for throwing light and introducing the subject. We'll proceed further from here. So Dr. Rachna, in her opening remarks, did talk about related disorders. So can I request Dr. Anu Vasu to talk about these related disorders and just throw a little bit of light on all the different related issues which come up with IBS.
Good evening, and thank you very much, sir, for all the kind introduction and for this opportunity to be part of this webinar. So, so the related disorders mainly divided into functional dyspepsia, functional constipation, abdominal migraine, and post-infectious irritable bowel syndrome. So, to distinguish between each of this, we have to have a proper evaluation. Like we have to spend a good counseling time or good symptomatology with the patient, basically to identify which category the patient falls into. Most of the time it is a bit confusing, but we have to spend a good quality time with the child or with the family to identify the triggers, identify what kind of symptoms it is. If you think about functional dyspepsia, the symptoms may be at least persisting for 6 months, or it will be like daily symptoms. The symptoms may be bit persistent, basically. And functional constipation, again, the symptomatology is a bit different. Mainly presenting with the constipation, and it can be associated with abdominal pain as well. Then when we think about abdominal migraine, there is a pattern of symptoms. Basically, it will be presenting with the with following certain triggers, or with certain aura kind of symptoms, or maybe like in between there will be symptom free episodes, and it's like a prototype of symptoms coming and going, basically. And another variant is post-infectious IBS. This is actually maybe a transient or something related to any chronic infections or something, basically.
So yeah, please go ahead.
Yeah. So this is again, I think, the previous panelist has been discussed about various types of IBS. This is basically we have divided based on the Bistow's stool chart. We can look at what kind of a stool basically, and if it is mainly constipation, this is IBS constipation associated. If the stools are mainly loose kind of stools, then it can be IBS as diarrhea stools. If it is both together, it's called as IBS mixed, or another variant is there, IBS unspecified as unclassified or something.
Thank you, Dr. Anu. I think so, however confusing it may look as of now, the illustration of actual cases hereinafter will probably clear the air. So to discuss the first case, can I call upon Dr. Rimjim Srivastav, please?
Yeah, thank you very much. A very good evening to all of you. At the outset, I would like to thank Central AHA for inviting me for this super specialty webinar. So coming to the case, let's analyze the case a little bit. The case is of a 14-year-old girl child. And the symptom she has presented with is basically recurrent abdominal pain for 3 months, which comes in the chronic category. So now a very important part in the diagnosis of IBS or for any type of functional pain is that we have to analyze the pain, whether it is chronic or not, whether it is recurrent or not, and whether it is associated with any constitutional symptoms or not. Like I take from this case that there is no fever or weight loss in this child, or there is no associated blood or mucus in the stool. A very important part in this any type of functional abdominal pain is that localization of the pain. Most of the children would localize this around in the umbilicus. If it is farther away from the umbilicus, there is more chance that it may be of organic origin. So if it is around the umbilicus, there is a chance that it's a functional abdominal pain. And very important thing is that whether the pain has got associated night awakening, whether nocturnal night symptoms are there or not. And this is a very important point to differentiate whether this is an organic pain or a functional pain. Now, another thing which you need to ask whether the pain is associated with relief by defecation or not. If it is not relieved by defecation, then if it is relieved by defecation, then it is a functional abdominal pain. If it is not, then it may point towards some organic origin. Another thing in this case is there is a very typical of alternating constipation and diarrhea, which is, as Dr. Anu has described, that there are 3 types of IBS with constipation, with diarrhea, with mixed, and there's another type that is unspecified, which we call IBS-U. Now, this child is having alternating constipation and diarrhea. The first diagnosis with this is irritable bowel syndrome if there is no other alarm signs. Another important differential with alternating constipation diarrhea is celiac disease, which we should not forget. A very important thing again in the history is relation, the trigger which is present. That is the symptoms worsen with stress, especially before exams. So if there are symptoms which is worsening with stress, like pain and bowel symptoms are worsening in the stress, that also indicates towards IBS. And this basically indicates that there is a disordered gut-brain interaction, and which is a very characteristic of irritable bowel syndrome. So what happens that whenever there is emotional stress, that leads to altered intestinal motility, and it amplifies the visceral hypersensitivity. So even with minute pain or with minute discomfort, the child feels that the pain is too much and the pain is unbearable. So this is the case of 14-year-old adolescent girl with recurrent abdominal pain, with alternating constipation and diarrhea, which is linked with stress, very important point. But there is no apparent red flag signs in the form of constitution symptoms or any other thing which would organic etiology. So this is basically abdominal pain related disorder. And I would like to add that there is a new term that is coming up with this kind of disorder, and that is called abdominal pain related disordered gut-brain interaction, APDGBI. So there are 4 things in this APDGBI. One is irritable bowel syndrome. Another one is functional dyspepsia. Third is abdominal migraine. And fourth is functional abdominal pain unspecified. So with these symptoms, we can think that the child is having irritable bowel syndrome, which is of mixed type. Now, the close differential in this type is one is celiac disease. They can present with such type of feature without any alarm symptoms also, and inflammatory bowel disease, especially Crohn's disease, which can present with such types of symptoms with diarrhea or with alternate constipation or without any red flag signs also. So, with investigation or with further detail,
So, Dr. Renjim, we'll come to the red flags and how to differentiate with the organic illnesses later on. All right. Okay. So, if you don't mind, can we just move on to the next case? Hello?
Hello?
Yeah. So, like I said, we will be having a separate
Sure. I'm not going to
slide.
tell the
Yeah. Okay. All right. Okay. So, thank you, Dr. Remjin. That was an excellent analysis, actually, talking about the periumbilical location. The further it is away from the umbilicus, more likely to be organic, absence of nocturnal awakening. And also, you've also very, very correctly pointed out about the gut-brain axis being dysfunctional. So we'll move on to the next case, and I'll request Dr. Remia Pai to please elaborate on this case of a 15-year-old boy.
Good evening. At the outset, let me thank Central IAP and AHA for having me here. Since I think everybody is feeling a little sleepy, I'll run through the second case. So here we have a 15-year-old boy with history of gastroenteritis for 6 months. Now he's having recurrent diarrhea with cramps. There is no blood in his stool and there is no weight loss. So as we discussed, he's having only diarrhea. So we know that there is history of 6 months duration, so we can label him as chronic. We know there is diarrhea, so we can label him as an IBS-D. As we already talked about, there are no red flag signs. And the only thing I need to add on from what Dr. Rimjim has added is when we do a good physical examination, we should always look for the perianal region. Because one thing we need to make sure to not miss is a inflammatory bowel disease. Though their symptoms, we might not get any red flag signs, which we'll be discussing later. But even in the first examination, we have to make sure that we do not miss any perianal lesions. It could be an abscess, it could be a fistula. So make sure we look at the the perianal region and make sure we're not missing anything else. And I hope we can go ahead with our further cases.
Thank you so much for that wonderful and very brief and pinpoint analysis. Thank you for putting in the pointer about the perianal examination. We'll now move on to the next case, in which I will request Dr. Anu Vasu to be elaborating on this particular case. Dr. Vasu?
This is a case of 13-year-old girl. So she has a history of very infrequent stools and abdominal pain relieved by defecation. So differentiating irritable bowel syndrome, constipation related from chronic constipation. So in this history, there is a typical history of abdominal pain, which is relieved by defecation. So when we think about chronic constipation, there may not be a persistent abdominal pain. So the persistence of abdominal pain is a very specific symptom. Basically, it may help us to distinguish between irritable bowel syndrome and chronic constipation. And especially the pain is getting relieved after passing motion. This is again more pointing towards irritable bowel syndrome. But when we are really looking into clinical practice, it may be a bit confusing for us because constipation also can cause some kind of abdominal pain from our practical experience. But whatever said and done from from whatever this case, it is more looking towards IBS constipation related.
Thank you, Dr. Vasu. The next case was due to be taken by Dr. Ashish Shah, but in his absence, I think so, you will be discussing this. So let's do this case, and can you please continue?
This is again a 16-year-old boy. He has recurrent midline abdominal pain, and he has associated nausea and pallor, sometimes triggered by stress. So This is a case of basically when we look at, so we had a discussion about abdominal migraine. Again, before the panelists has been discussed in detail, basically. So this is a can you go to the previous slides, sir? So this is mainly the symptom is triggered by stress and which is associated with nausea and pallor. So abdominal migraine has characteristic symptoms related to the typical migraine onset. It can be a trigger and it can be associated with nausea, and the symptoms will be similar. Every time whenever the symptom occurs, it will be having a similar prototype pattern basically. So this is more pointing towards abdominal migraine. And usually the symptoms will be episodic.
Yeah. And any differentiating features from functional dyspepsia?
Functional dyspepsia maybe it's like a persistent symptoms and it will be chronic. Usually will be having a abdominal pain and it may not be episodic or may not be following the same triggers or may not be associated with always associated with nausea, and the severity also may be varying. The abdominal migraine may be more severe when compared to functional dyspepsia symptoms. And I think these are the main distinction features between these two, I think.
Yeah. So mainly talking about episodic versus chronic, then associated migraine features. That is how you would be differentiating between the functional dyspepsia and the abdominal migraine. Thank you so much, Dr. Anu. We will now move on to the next case. And this specifically will be flagging the red flags. So I'll request Dr. Rachna Kathuria to take us through this case.
Thank you, Dr. Shamik. So this is a 15-year-old girl who has chronic abdominal pain along with weight loss and has occurred blood in stools. So if we look for the red flags in this scenario, there is weight loss. Remember that the weight loss should be documented and it should be involuntary and unintentional, like the girl should not be doing some dieting or all. Then there is blood in stools. So these are the two red flags. Similarly, there are other red flag signs, although not in this scenario, but we should be aware what are the red flags which require investigations. So there can be red flags like there can be persistent vomiting, there can be dysphagia or odynophagia, there can be severe abdominal distension, there can be nocturnal awakenings. So nocturnal awakenings does not mean that when there are nocturnal, people say that there is nocturnal pain. We need to differentiate that a nocturnal pain does not mean that the child has difficulty in sleeping because of getting to sleep because of pain. Rather, it is that the child awakens in the mid of the sleep because of pain. So that is important. So nocturnal awakenings are important. That is a red flag. Then if there is any growth delay, if there's any delayed puberty, if there's any unexplained fever, if there are extraintestinal features like there's arthritis, there's perianal disease, or if there is a family history of IBD, celiac disease, all these are red flag signs. So in this case, since we are finding few red flags, these are the alarm symptoms and signs, and we need to do the workup, detailed workup of this patient, not just for inflammatory bowel disease, which is one of the diagnoses, but for other organic diseases as well, which can be tuberculosis, it can be like autoimmune disease, it can be SLE, it can be malignancy. So we need to investigate this child for other systemic illnesses and other organic causes.
Thank you, Dr. Rachna. So we've had a fairly elaborate presentation of the different kinds of irritable bowel syndromes. We would now move on to, and I will request Dr. Rimjim Srivastav to be telling us about what exactly needs to be used in diagnosis so that we can come to a firm diagnosis, and if any investigations are needed.
Sure. So the diagnosis of IBS should have a positive diagnostic strategy rather than it should not be a diagnosis for exclusion. So the diagnosis of IBS is basically a clinical. So you don't, most of the time you don't need any investigations to diagnose it. The first and very most important thing is that taking detailed history and a thorough examination should be done, as has been explained already. We have to identify the alarm symptoms or red flag signs, whether they are red flag signs or not, in the form of weight loss, poor growth, GI bleed, diarrhea, etc. Any family history of IBD or celiac disease, etc. is there or not, we have to make it clear. And after that, we have to apply the room for criteria, which has already been discussed, and subtype, and the child, whether it belongs to IBS-D, IBS-C, mixed type or unspecified type. A very important thing is that even in children, those who are not having unspecified type, or those who are having only diarrhea, occult constipation should be always asked for. And with this, we can rule out the organic diseases and then classify and make the diagnosis. So basically, generally, we don't require any investigation. Basic lab, can you move on to the next slide, sir? Basic lab investigations can be done. So a very important thing is that even the child is not having any alarm symptoms, but there is a chronic diarrhea is there. A celiac disease should be ruled out, because celiac disease may most of the time present with anemia and growth faltering, but they can present without any growth hampering or anemia also. So if there is chronic diarrhea, celiac disease should definitely be ruled out. Another very important thing is to investigate in such child who is having long-term diarrhea is to differentiate it from inflammatory bowel disease. And a very simple test for that is estimation of fecal calprotectin. So this is basically a non-invasive screening method for intestinal mucosal inflammation. If a child is having diarrhea and the fecal calprotectin is normal, that is less than 50 microgram per gram, then you can absolutely be sure that this is a functional origin and this is not inflammatory bowel disease. But if it is more than 200 or 250, even without any alarm symptoms, then you have to investigate the child further, because the child may have inflammatory bowel disease. Another test is to check for inflammation is you can get CRP done if you are suspecting that there could be inflammatory bowel disease. Stool test, etc. are not required for the diagnosis of IBS. Colonoscopy can be done if there are alarm signs. Imaging, like even plain X-ray can show you sometimes that the child is having occult constipation, or even in ultrasound you can get that there's fecal loading or a thickening of intestine is there. So very minimal tests are required for the diagnosis of IBS, and mostly it is a clinical diagnosis.
Thank you so much, Dr. Nimjin. That was so beautifully put. Let us now move on to the management, and I'll request Dr. Remya Pai to throw some light on the lifestyle changes and the diet that needs to be followed in IBS.
We know that the disease can be quite distressing to the parents and the children. Similarly, the advice that we need to give, we need to sit with them and talk to them about how lifestyle management and change in their diet can actually bring a significant change in the disease or the symptoms that the child experiences. So talking to them and understanding what type of diet the child is having and modifying the diet actually makes a lot of difference. So hydration, yes, and regular meals, definitely. And we talked to them about going ahead with a low FODMAP diet. So what is low FODMAP, or what is FODMAP? FODMAP is nothing but fermentable oligomonosaccharide and polyols. They're actually a group of carbohydrates which are poorly absorbed in the small intestine, and they get fermented in the large intestine. So when they reach the large intestine, they draw a lot of water. Along with that, they produce a lot of gas. And along with that, what do we have? We had a lot of bloating, there'll be pain, and there'll be a lot of diarrhea, especially in these sensitive individuals. So this must not happen in all the people, but more in the sensitive individuals. So these individuals, we have to make sure that they go ahead with this low FODMAP diet. So there is poor absorption of these diet in the small intestine. There is water attraction, there is bacterial fermentation and intestinal stretching. So what we ask them to do is first a complete elimination of the diet in the initial phases. Once they start becoming better, we can slowly reintroduce them, or then we can slowly, personalize them according to the child's requirement, and slowly increase the dietary fiber as a child is tolerating. And definitely more physical activity, definitely reduce their screen time, have a more healthier atmosphere, go outside, make more friends, like in the olden times. That is definitely going to make a very significant impact in reducing their symptoms.
Thank you so much, Dr. Remya. we've heard about the fact that it is the gut-brain axis. So what are the roles of psychological management and pharmaceutical management in cases of in cases of the IBS? So I'll request Dr. Anu Basu to please throw some light on this.
Yeah, as what Ramya said, it's all about the gut-brain interaction, and it's very difficult to say a blanket therapy for all the children altogether. So it should be individually tailored approach basically. So as what we have again discussed, it will take quite some time to identify what are the triggers and what are the thought process, how are their feelings, and how it is related to their symptoms and behaviors. So identifying all this spectrum will help us to manage this through cognitive behavioral therapy and things. Cognitive behavioral therapy, first of all, we have to identify what are the stressors. We have to identify what is the family situation they are in. So, to identify all these connections, help us to refer the child for a cognitive behavioral therapy. And once the stress factor, we could able to relieve the stress factor. It's easy to treat them with even medications. So, more than cognitive behavioral therapy, hypnotherapy is also being recommended in the latest SPGAN guidelines and ASPGAN guidelines. So, all these are not as what I discussed. Each and every patient has their own needs and their own demands. So depends on that only we have to move forward with all these kind of therapies. So even physical activity, some physical exercises help them to relieve their symptoms sometimes. And these are the main psychological approach mainly we are approaching at cognitive behavioral therapy and hypnotherapies. And when we think about antispasmodic laxatives and probiotics, so there is not much of a proven role for probiotics and symbiotics for everyone, but there are some studies which have shown it is effective. But there is not much of evidence to suggest to give probiotics for everybody who comes with the irritable bowel syndrome. But it is proven that some kind of lactobacillus, some kind of probiotics may help. So we can prescribe depends on each and individual patient who comes to us basically.
So the
So
key
then,
word is individualization of the therapy, isn't it?
yeah, exactly.
Thank you. Thank you, Dr. Anu.
Yeah.
I will now move on to some basic principles of counseling that is so very important in managing these patients. So Dr. Rachna, if you can throw some light on this.
Yeah, so for the counseling part, we need to have basically a multidisciplinary approach. We need to understand that first of all, the doctor-patient relationship should be very good. And the doctor needs to be very empathetic and compassionate and needs to understand the challenges being faced by the adolescent. Acknowledge that the adolescent is suffering from a problem. That is important because many people misunderstand that the child doesn't have any problem. The problem is in the brain. No, this is a brain-gut axis problem, and the child is actually feeling that visceral hypersensitivity, and the child is suffering. So the adolescent is suffering, and the doctor and the family needs to realize that. So acknowledge the problem. Secondly, explain in a simple form to the parents and to the adolescent regarding this whole brain-gut axis and make them realize that yes, the problem is there and there is a solution, and that this will not be a miracle. There will not be a miracle. It will not be cured in a single day. It will take some time. So that will, making that situation more realistic, creates a better bond between the doctor and the patient and the family. And apart from that, we need to educate the family regarding the triggers for this. Like there are different triggers. There might be dietary triggers. There might be stress. There might be psychological factors which might be triggering this event. So the family needs to be educated about this. Apart from this, there needs to be we need to give cognitive and behavioral therapy to the child, as one of the previous speakers told us. And we also need to identify if there is any individual or family stress which is going on in the background. because we have seen cases where the child presents with abdominal pain, and finally when we talk to that patient, we realize that there's a family discord, there's a discord between the parents which is going on. And at times it happens that the child is having, just for secondary gains, he is feeling that visceral hypersensitivity and he's manifesting with these symptoms. So eliminate the family stressors, give a good caregiver support, social support to the child. The child might be suffering from various anxiety, mental issues and psychological issues. So give support to him. He might not be performing well in school because of disturbed sleep and because impaired quality of life. So the child needs to be supported. And the multidisciplinary approach does not mean that only a pediatric gastroenterologist or a gastroenterologist has to deal with this. We have to make the counselor and the psychologist come on board. The behavioral therapist needs to be there. The dietitian needs to be there who counsels regarding the diet without restricting the nutritional requirements of the adolescent, because that is a growing age group. So she will monitor both the nutritional requirement as well as the restrictions which are required. And there also needs to be a primary care support mechanism where educational messages are given to this family and the adolescent, and it's been tracked and followed up well that the child is following them. Also, the family and the caregiver is also one of the main stakeholders, main partner in this management.
Yeah.
Thank you.
Thank you so much, Dr. Rachna. Just to sum up our understanding of today's discussion, we have a couple of MCQs. I will request the audience to type in their answers in the chat box, and I'll request Dr. Anu Vasu to take us through the two MCQs. So that's the first one. Dr. Vasu. Dr. Anu Vasu.
Yeah, sorry, my speaker was off. Yeah, sir. This is a 14-year-old girl with alternating bowel habits and pain relieved by defecation. Best diagnosis.
So we'll give them a couple of minutes to type in their answers. Right. Dr. Anu, you can just give an explanation of what you think is the right answer.
So I think it's option B, irritable bowel syndrome, mixed child. So we have already have a discussion. This is alternating bowel habits and abdominal pain, which is typically relieved by defecation. So it's more suggestive of IBS mixed variant.
Thank you so much. Can you take us through the second one?
So which is a red flag in abdominal pain? Nocturnal pain, relation to stress, relief with defecation, normal growth.
Give them a few moments to type in their answers. Okay. So
yeah,
if you can
I
give
think
the
all of them
explanation.
got it correct. It is nocturnal pain. Yeah. So
okay, thank you, Dr. Anu, for taking us through the MCQs. This is just to test the understanding of whether we've been able to give some key messages. And to summarize those key messages, can I please request Dr. Rinjim Srivastav to do the summary?
Yeah. So IBS is common in adolescents and it impacts quality of life. So it is basically a functional disorder of gut-brain interaction. The diagnosis is clinical. We don't need most of the investigations. Rome 4 criteria is the best criteria. And there should be a high index of suspicion to diagnose irritable bowel syndrome. You should always check for alarm features and stress triggers, which will define the irritable bowel syndrome. You don't need any investigation, but yes, even if diarrhea is there and the long-term diarrhea is there, you should always rule out celiac disease. And if at all, if you're suspecting, then Crohn's disease also should be ruled out. As discussed, simple investigations are there. And the management is multidisciplinary. Lifestyle, diet, stress, medication, all these things have been discussed. A very important thing in the counseling of family is that we should always explain that there is a benign nature of this condition, and in most of the patients who are well managed, the prognosis is very good.
Thank you so much, Dr. M.C.M. Srivastav. That brings us to the end of the panel discussion. I hope we've been able to give some messages. I'll just stop sharing my screen here. Thank you so
sir.
much. Yes.
Thank you, Dr. Samik and the panelist. बहुत अच्छा IBS के ऊपर वो था discussion और सबने enjoy किया उसको.
So we'll move on to the youth section, and if you can introduce Dr. Kalyani Parihar, and then I will just ask her a few questions from the youth perspective, so that
Dr. Kalyani Parihar is a young, energetic pediatrician, and she is answer your questions.
Yeah. So Kalyani, welcome. Welcome to this last bit, and please allow me to introduce you also to our audience. So Dr. Kalyani Parihar is a very, very young person, but very devoted to this particular subspecialty. She's done her MBBS from Nagpur, her MD Pediatrics and DNB Pediatrics fairly recently in 2021 and 23. And currently, she's pursuing her FNP in Pediatric Gastroenterology and Hepatology from the Postgraduate Institute of Child Health in Noida. So welcome, Kalyani. What we will be doing today in this section is that we would be trying to take the youth's perspective on what these problems can mean to the youth. So I will act, or I will simulate the youth questions, and I will request you to give an answer which would be understandable in a language that the youth can understand. So, Dr. Kalyani, as an adolescent, I would really like to, I've heard of the term IBS, but can you explain it to me? Why is it so common in the teens, and what should we know about it?
So basically, IBS stands for irritable bowel syndrome. Though it's not a very organic pathology, but it is fairly common in adolescents, especially because it has many triggers, and one of the major trigger being a psychological or a daily stress. So as we all know, the adolescents are going through a lot of changes in their school, their academics, their body changes, their personality changes. So all this can act as a trigger. So even the smallest of a trigger will lead to a different type of coping in these children. And because of that, there is development of visceral hypersensitivity or increased motility. And on top of that, I think in today's era, where the junk foods are very common and children, adolescent now can go out and eat a lot. So that also contributes to the dysbiosis, and hence this becomes fairly common in adolescent age group.
So, doctor, I mean, it's fairly clear to me that, exams, stress, they can have multiple triggers. But really, are there any specific foods that I should be avoiding in IBS?
Yes, sir. So as we all know, that while treating the IBS, we give a trial of FODMAX, which is directly linked to increased carbohydrate intake, increased intake of preservative, junk food. So these are the food which will alter your intestinal microbiota. These are the food which will cause more bloating when they go to the intestinal lumen. They'll drag the water because of the osmotic load and cause the distension. And IBS people already have a increased sensitivity to slightest of these distension. So these are the patients who are going to perceive more and more pain. So these are the type of food like junk food, carbohydrate rich food, preservative rich food we are supposed to avoid.
Okay, ma'am, it is sounding fairly scary to me as an adolescent. Is this curable, or is this something I'll have to live with lifelong?
as already discussed in this panel, that this is it can be very disturbing to both parents as well as child. It can lead to some school absentees or academic losses, but it does not have a very long-term morbidity or mortality. So with proper treatment, counseling, and follow-up, it is definitely treatable. There is nothing to be worried about, but we need to have an understanding of the disease and follow what doctors are advising us.
Right. Doctor, as an adolescent, let me be very frank. It's very embarrassing to talk about my stomach or my bowel habits, right? So, any particular methods by which we can talk to my parents or to my doctors about these issues?
Yes, so if we go and if as a pediatrician, whenever we ask to an adolescent, how are your stool, how is your habit, what was the color, the first expression they give to us is like gross. So this is the word they will use because they associate it with the bad smell or something very personal to them. So they don't want to share that. So if we are following up a child with IBS, what we can do is we can show them the Bristol chart. We can ask them to bring a diary, which we can call it a gut journal or a gut diary. Like psychologists give you a journal for journaling. We can give them this diary so that we can have a track of their bowel habits as well as the stressors and what is happening. So these are the way where they'll have less to talk, but we can have more objective evidence of their bowel habits, and also to avoid the terms, like explain to them that these, as a gastroenterologist, we daily basis we deal with stool and all that, so nothing gross about it, so as normalize as we can.
That's very reassuring, Doctor. I mean, as adolescents, we are extremely inclined to go to the gym and, improve our, muscle growth. So all these exercises, do they really help in the digestion of food?
So when it comes to digestion, it is a multi modality approach. We need to take care of what they're taking, and also how is our psychological health as well as how is our physical health. So definitely all three will help. Exercise does help in overall stress relief also, as well as increasing your gut motility also. So it does help, but not only just exercise, but also diet as well as taking care of our mental health, and developing those coping mechanism will also be very important.
Okay, Doctor, I won't keep you waiting too long, but just one last question. As in our age group, we go through a lot of reels, and almost there are frequent reels which talk about consume this probiotic, consume that probiotic. There is some prebiotics, there are some things called symbiotics. So, what are these substances? Are they any natural substitutes, or what are they?
So
And how do they affect?
Prebiotics are basically food for the bacteria which are already there in our gut. We have good bacteria as well as bad bacteria, and all these problems are arising when the balance is dislodged. So to give food to the good bacteria, we need to consume these prebiotics. And though it's a very fancy word, they are simple products. For example, fermented food, which we can include in our daily diet. For example, dosa and idli. Yogurt is a very good prebiotic. So these basic things which we can include, which will act as a prebiotic. And probiotic, yes, if your doctors are prescribing, you're supposed to have it because there is some evidence, but only on prescription basis, not a routine like nowadays. On internet, you can find many probiotic, prebiotic supplements. So don't fall for that. But if your doctors are prescribing, definitely it will be helpful.
I'm really sorry, but again, one last question. I know you are a gastroenterologist, but can I come to you for counseling?
Yes, sure. As a pediatrician and gastroenterologist, all the pediatricians are trained for how to speak to a small child as well as a adolescent. So yes, we can definitely help. And we also know the red flags when we have to refer, when it is out of our counseling skills. So at that point, we will refer also. But definitely, we can be a friend as well as a treating doctor. So definitely, you can approach anytime.
Thank you so much, Dr. Kalyani, and thank you for your wonderful time. So that ends our session today, and I will request Dr. Shushma Desai to please come in and say the final words, and then we can have a vote of thanks from Dr. Sneha. Because it's already 11 o'clock. Dr. Nagendra has been very kind to answer a lot of questions on the chat box. Any particular unanswered questions? No, I don't think so. I think so. Most of it.
There are,
most
of them are answered.
So, Dr. Shushma Desai, are you there?
शायद मैडम के उधर उसकी प्रॉब्लम है.
Okay. I'll request Dr. Geeta Patil, if you can please, summarize, end the session, and then we can have Dr. Sneha giving us the vote of thanks. Dr. Geeta Patil. Dr. Geeta Patil.
मैडम तो है.
Okay, Dr. Prakash Arya, I think so you can conclude. And then the vote of thanks by Dr. Sneha.
आज का सुपर स्पेशलिटी वेबिनार बहुत अच्छा था एंड उसमें डॉक्टर नागेंद्र जी ने सबसे पहले जो हेपेटोबिलियरी डिजीज के बारे में बताया और फैटी लिवर के डायग्नोसिस एंड मैनेजमेंट कर रहा है. इट्स रिमार्केबल एंड बहुत बढ़िया था. बाद का जो डिस्कशन पैनल डिस्कशन डॉक्टर शामिक जी ने और डॉक्टर रचना, अंजू, अक्षय, रिमया जी एंड रिमझिम जी ने बहुत अच्छी तरह उनके क्वेश्चंस के जवाब दिए. थैंक यू. बस.
Dr. Sneha, if you can have your vote of thanks, please.
My work has